doctor or nurse, how do you talk to them? Did you know healthcare providers base most of their medical decisions on what you say to them? But most healthcare providers are rushed because they have so many patients. It's important to make the most of the time you have by being brief and to the point. Here are a few tips. Before you go to an appointment, think about what you want to say and how you'll say it. What are you most worried about? What are you hoping to get out of the appointment? Organize your thoughts. Think about how to describe your problem. Has it changed over time? What makes it better or worse? Write down your questions or record a voice message to help you remember. Do your homework. If you can, look up your symptoms online or in a health guide. Having some knowledge will help you have a more informed conversation. Take a friend or family member with you, especially if you have a language barrier. Ask the provider to explain their reasoning for your diagnosis and treatment. Repeat out loud what you understood them to say. Before you leave, be sure that you and your provider agree on the next steps. Ask what to do if your condition changes. Always be respectful and courteous and expect the same in return. Healthcare can only work well if you and your provider are working together. To learn more, visit the World Health Organization Patient Safety Flagship or visit our website at www.org. World Patients Alliance, the global voice of patients.
Just didn't feel right.
We had so many questions.
They didn't listen to us, again and again.
No one told me what went wrong.
We all have the right to safe healthcare.
Each one of us.
Most of the harm caused to patients can be avoided.
Safety starts with us.
We have the right to ask questions
And to get answers.
To express our opinions and concerns.
To know if something went wrong in my care.
When I include patients and families as members of the health team,
care becomes safer.
When I listen to my patients.
When we are transparent.
When we learn from patients' experiences.
When we make decisions that include patients' voices.
When we partner with patients and families.
We save lives.
When I am heard, I can make a difference in my own care.
And the care of others.
Together,
we can achieve safer healthcare.
For everyone.
Teman-teman pasti udah pada tahu kan Pusat Riset Keselamatan Pasien? Pusat Riset Keselamatan Pasien telah berdiri sejak tahun 2018 dan mempunyai visi besar untuk berkontribusi dalam peningkatan kualitas pelayanan kesehatan dan Riset Keselamatan Pasien mendapatkan hibah Kementerian Pendidikan, Kebudayaan, Riset, dan Teknologi untuk menjadi pusat unggulan di bidang mutu dan keselamatan pasien. Oleh karena itu, mulai tanggal 17 September 2023, Pusat Riset Keselamatan Pasien akan berubah nama menjadi Center of Excellence for Patient Safety and Quality, atau Pusat Unggulan di Bidang Mutu dan Keselamatan Pasien. Nantikan sederetan aktivitas kita ya. Mari berkolaborasi untuk meningkatkan mutu dan keselamatan pasien di Indonesia. Jangan lupa untuk tetap share and save lives. Get ready, let's participate, let's collaborate.
Mendapatkan pelayanan yang aman dan sesuai standar adalah hak asasi pasien. Keselamatan pasien telah menjadi isu global yang sangat penting dan tidak bisa diabaikan. Insiden yang berpotensi untuk mengakibatkan cedera atau kematian pasien dapat terjadi di rumah sakit, puskesmas, maupun instansi pelayanan kesehatan lainnya. Padahal, insiden keselamatan pasien sebenarnya adalah sesuatu yang dapat dicegah. Pusat Riset Keselamatan Pasien atau Center for Patient Safety Research Universitas Airlangga adalah research group yang berfokus untuk meningkatkan keselamatan pasien melalui edukasi dan penelitian. Dengan visi dan misi, Pusat Riset Keselamatan Pasien membahas tentang beberapa tema strategis yang mencakup pemenuhan hak pasien, kehidupan sehat dan sejahtera, meningkatkan kualitas hidup manusia, pembangunan manusia dan masyarakat, serta manajemen kebijakan dan sistem kesehatan masyarakat. Program kerja tetap Pusat Riset Keselamatan Pasien yaitu penyelenggaraan sosialisasi atau edukasi, rekrutmen pelayanan kesehatan mitra, penelitian dasar maupun terapan, kolaborasi, publikasi di jurnal nasional dan internasional, serta kegiatan pengabdian masyarakat. Dukung perkembangan keselamatan pasien di Indonesia dengan follow akun Pusat Riset Keselamatan Pasien. Share and save lives.
An introduction to medication safety, brought to you by World Patients Alliance, www.worldpatientsalliance.org. Do you take medications? Almost everybody does. But what do you know about medication safety? We all need medications sometimes, but medications are powerful agents that need to be used with care. Did you know? Medical error is one of the leading causes of death and disability in the world. About half the harm from medical error is caused by mistakes with medication. At any given time, about every 10th person in the hospital is there because of harm from medications. Medication use has increased by about 1/3 over the past decade. As the number of medications goes up, so does the risk of harm. Not all harm from medications can be avoided. Need and know more. What can you do to take medications safely? Know what each medication is for and how long you should take it. Know the potential side effects. Be careful of over-the-counter medications. They can have serious side effects just like other medications. Take the smallest dose you need. Keep a list of your medications. Review your effects to your prescriber or to your National Center for Reporting Adverse Drug Events. To learn more, visit the World Health Organization or visit World Patients Alliance, www.worldpatientsalliance.org. The global voice of patients. Are you taking too many medications? How many medications do you take? Do you take more than 5? That is called polypharmacy. Many medications can hurt you if you're not careful. That's especially true if you're a person over 65. Did you know? Medication side effects are responsible for about half the harm from medical error in the world. Most serious harm from medications occurs in people who are over 65 years old and taking 5 or more medications. Over-medication of senior citizens is a problem in every part of the world. Older people often take multiple medications because, as we age, we develop health conditions like high blood pressure, diabetes, or heart problems. But sometimes, people take medications they don't really need, or that should not be taken together, or they take them for longer than needed, and some drug doses need to be reduced for older people. How can you find out if your medications are all safe for you to take? Review your medication list with your healthcare provider. Include everything you take. Even non-prescription medicines, like vitamins, can sometimes be unsafe when combined with others. Learn about your medications. What are their names? What are they all for? What are the signs of side effects or overdose? Ask how well the medication works and what would happen if you didn't take it. Sometimes the side effects are worse than the condition for which you're taking it. To learn more, visit the World Health Organization Medication Safety Challenge or visit our website at www.worldpatientsalliance.org. World Patients Alliance, voice of patients.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Excellency, the head of PUI PT Center of Excellence for Patient Safety and Quality, Dr. Inge Damanti. Respectable the speakers of this webinar. Professor Tan Kok Hian from Sing Health Institute for Patient Safety and Quality from Singapore, and Dr. Francis Hugh Chang from Fulbright Specialist Patient Safety and Quality Expert from US, and also the moderator, Dr. Sylvia Sumitra, MBBS, and honorable of the committee and all participants of this webinar. First of all, let me introduce myself. My name is Lukita Ayu Puspitasari, will be your host of this afternoon. Okay, ladies and gentlemen, welcome to today's webinar series, Patient Safety Open Disclosure Practice in the US and Singapore Hospital. We'd like to thank everyone for making time to attend this webinar series. But before we start the agenda, the committee will help us for the documentation. So, committee, the time is yours.
One, two, three. 1, 2, 3. Okay.
Okay, thank you very much. Now we move.
I can open the camera.
Okay, thank you very much. Now we move to the webinar agenda, and also this agenda will be guided by Dr. Sylvia Sumitra, MBBS, as the moderator. Okay, Dr. Sylvia Sumitra, the time is yours.
Thank you, Lukita. Good afternoon, ladies and gentlemen. Good afternoon, our honorable panels, Professor Tan Kok Hian, Dr. Chang, and also Bu Inge, and the committee. Thank you for the opportunity. I'm Sylvia Sumitra, and I will be your moderator for today. I think the topic is very interesting and very important because we will learn a lot of things from the experts about open disclosure practice. What is open disclosure, why it is important, and even though we already known about it, it is still very hard to really implement, especially in Indonesia, because being blamed or getting sued and everything. So we will learn from the experiences of our experts. And before we start with the presentation from our speakers, I would like to read the curriculum vitae of our speakers. Okay. For the first speaker is Professor Tan Kok Hian, MBBS, MBA, MRCOG, MEd, PharmS, FRCOG, PA from Singapore. Professor Tan is Group Director and Senior Associate Dean at Sing Health DUKE-NUS Institute for Patient Safety and Quality, which was set up to enhance patient safety and high reliability care with the aim of target zero harm. He serves as advisor to Care Women's and Children's Hospital Patient Safety and Risk Council. He is a senior consultant maternal fetal medicine specialist in the maternal fetal medicine department and is head of in KKH. Professor Tan was the inaugural chair of Singapore National Quality Council from 2017 to 2021, which served as the National Advisory Panel to Singapore MOH on health quality priorities and strategies. He is a member of the Singapore MOH National Performance Steering Committee and is MOH Cluster Deployment Lead for Sing Health in Singapore National Framework to advance Singapore healthcare towards high reliability. Prof. Tan initiated the Sing Health Patient Advocacy Network in 2017 and currently serves as an advisor. He started and leads the Academic Medicine Enhancing Performance, Improving Care framework in Sing Health, which is an educational and professional development framework that comprises a portfolio aimed at patient safety, quality, and innovation capabilities of staffs and patients. Professor Tan is conferred the Benjamin Henry Professorship by DUKE-NUS for his outstanding contributions in the field of obstetrics and gynecology since 2019. He received the WHO United Arab Emirates from 2009 as Integrated Perinatal Care Project Team Leader for KKH and was awarded the Singapore Inaugural National Outstanding Clinical Quality Activist Award 2010. He is the Pro-Director of DUKE-NUS Medical School Graduate Certificate in Patient Safety and Healthcare Quality and National University of Graduate and Master in Patient Safety and Healthcare Quality. Professor Tan is a member of the expert for WHO and has served as a technical consultant in patient safety and healthcare quality for the MOH in Sri Lanka and Maldives. Global Patient Safety Action Plan 2021 to 2030 and initiated the Global Action for Leadership and Learning Organizations on Patient Safety since 2021 to work collaboratively towards zero patient harm in healthcare globally. He initiated an MOU in 2023 for Sing Health to work with WHO as collaborative partners on the WHO Asia Pacific Patient Safety Network platform, the creation of Global Knowledge Sharing Platform for Patient Safety for global sharing of learning, safety incidents, and practices to encourage mutual learning for reducing patient harm and the global development of a safety culture guidance. And our second speaker is Dr. Francis Pancho Chang. His education and Fulbright specialist at U.S. State Department, Washington, D.C., Woodrow Wilson Visiting Fellow at the Wilson National Fellowship Program, RBF Minority Teacher Fellows at the Rockefeller Brothers Foundation, New York, and still so many fellows. And here are the backgrounds of his professional experience from 2023 to present at El Camino Health, Mountain View, California, as an appointed member of Board Quality and Patient Experience Committee for Public Nonprofit Health System with 2 nonprofit acute care hospitals and primary, specialty, and urgent care centers across Silicon Valley. 2014 to present at the Patient-Centered Outcomes Research Institute, Washington, D.C., as stakeholder reviewer, Eunice Kennedy Shriver National Institute of Child Health and Human Development, Bethesda, as the initial review group member, Health, Behavior, and Context Subcommittee, at the Ravenswood Family Health Center, East Palo Alto, California, as a strategic business advisor, and Chief Operating Officer at the Asian Americans for Community Involvement San Jose, Executive Director at the Walter S. Johnson Foundation, Menlo Park, California, Senior Program Officer in 1997 to 2001 at the S.H. Cowell Foundation, San Francisco, Program Officer at the Kaiser Family Foundation, Menlo Park, Director of Hospital Community Benefits at the Boston City Hospital, Acting Deputy Policy at the Bureau of Primary Care, Rockville, Executive Director, Assistant Administrator at South Cove Community Health Center, Boston, as an attorney at the Legal Aid Society of Alameda County, Oakland, California. Well, now we already know the backgrounds of our incredible speakers today, and we will begin the presentation for our first speaker, Professor Tan Hian. I would like to invite you to give your presentation. Please, Professor Tan. Thank you.
Okay, good afternoon, everyone. Thank you, Sylvia, for your kind introduction. And thank you, Dr. Inge and the Patient Safety Center in Airlangga University for inviting me to give this talk. And I think the open disclosure is a very important process. And for us in Singapore, it takes some time to grapple with it. And I do hope that the whole world will be able to practice it in the best possible way. So I will talk something about what is happening in Singapore, especially for my experience. I have engaged in open disclosure as a clinical quality director since 2004. I was formally trained and certified in open disclosure in 2009. And we do teach that as a topic in our graduate programs in patient safety, healthcare quality in the US. Session 20 minutes or so to examine the need for it, to discuss what is happening in Singapore, examine some components of the effective open disclosure. Open disclosure has to be effective, and to look at some key issues. Very importantly, as what Sylvia mentioned, the action plan, I think, sets forth us to have a better patient safety environment in the world, which is to avoidable harm. And one of the important factors relating to patient and family engagement. And in this particular strategy 4.4 is to strengthen the practice of openness and transparency throughout healthcare, including through patient safety incidents disclosure to patients and family. Just now we have watched the videos. I think the families, when the videos, they have a lot of questions. The healthcare staff doesn't listen to them and they need answers. And it's very important to actually do this well, because that promotes healing for the patient, as well as the fact that we are good healthcare providers for the doctors, nurses, and the allied health. So in Singapore, we have achieved much in healthcare. In fact, I would say our system is probably one of the best in the world in terms of cost and cost-effective delivery. And however, one of the issues that keep on cropping up is the issue of medical litigation. I'm from OBGYN. I know it can be quite a big issues, and huge sums are involved. There's also the rising expectations of the patient and public in relation to the care. And sometimes this expectation can be overtly high and unrealistic. And that gives rise to a lot of misunderstanding and issues about the care that we can provide. And sometimes it didn't go well, and that makes it worse. So we understand that in US and maybe Australia, there's multi-million-dollar claims and medical legal bill, and these are quite common. And this actually increase healthcare costs, because if there's a huge award, it actually increases the social cost in terms of the premiums, in terms of the care, the subsequent healthcare costs itself. So it's important to ensure that this stays low, and is to reduce the adversarial situation between patients and healthcare providers. What we call this is a growing crisis. Journal. It is also known that open disclosure, if it's done well, can reduce litigation, reduce the intent of the litigation, reduce cost of the incident as we manage. And in fact, this is almost like 15 years ago. This article in Annals of Internal Medicine shows that if you do it well, hospital admits a mistake, the chances that you get sued is markedly reduced, and the reputation of the physician and hospital can be enhanced. It's also a step that we enable us to look at how we can do prevent from happening again when there's open disclosure trying to resolve. So that is important, and we should need to practice that as well. One of the fortunate things that happened in Singapore is the way our medical legal system has evolved. When in 2004, when Chief Justice Sundaresh Menon became the Chief Justice, we invited him to give a talk, and at that talk, he discussed about the merits of enhanced use of mediation before litigation, the need to reduce adversarial approach, and the need to use medical assessors in recognition of the limitation of judges. And I must say that since then, he has implemented most of this to the benefit of the Singapore court system. And very important is that we need to get everybody together, doctors, nurses, allied health, lawyers, legislators, to come together to address this medical legal crisis. And one of that is the open disclosure, doing it well. So in Singapore, we also are fortunate to have a policy that gives us the legal protection for members and findings when the error occurs or when the incident occurs. There is this medical assurance committee is set up, and the proceedings are not discoverable. Basically, that they are protected. So everyone is encouraged to say openly what are the issues and how to prevent such an incident from happening again. The for hospital in SingHealth, for example, for patient complaints and alleged malpractice. Everything revolves around a department. In this case, is the OPE, which is the Office of Patient Experience. In the past, we would put it as the Department of Medical Affairs or the Department of Patient Safety and Risk Management. So there's a group of people looking at when there's a complaint, when there's an incident, to collect the information and to provide the patient with the necessary information as well. And they will collect all the data and determine how serious it is. Usually a hospital review is done to look at issues relating to the complaint, and in terms of whether there was any errors, or whether there was in terms of the system issues, or in terms of our doctors and nurses, in terms of so-called suboptimal practices within that cell. And after all the information is taken, that there will, before we meet the family in a family conference or give a written response, there will be an internal meeting to discuss what would be the strategy. This is to be fair to the patient and to be clear to everyone what has been found, right? So there's an internal meeting there. So there's a deadline relating that. And after that, the internal meeting, there will, of course, be a family conference or written response. And depending on the patients, sometimes it can be there be resolution just from that alone. But however, if there's no resolution, then it goes on before litigation. As I mentioned just now, our Singapore legal mandate sort of a mediation. And the mediation can be a variety of type of mediation, those without lawyers, those with the lawyers present. A process before litigation is involved. Because if litigation is involved, it's actually, I think, costly for both the hospitals, the staff as well as for the patients. It is quite a deep challenge for even a patient to sue a doctor, because you really need to have the necessary resources to do so. So open disclosure basically is actually refers to the open communications, and is one of the key things is actually an expression of regret, a factual explanation of what happened, to look at the consequences and steps being taken to manage, to prevent the recurrence again. The ethos is that if we do this well, this will assist the clinicians to respond as best as they could and minimize the harm to everyone. So when to do open disclosure, whenever there's disappointment and there's a complaint, it is a role for us to actually talk to the family. And this has become an important part of every clinician role itself. We don't need to wait for the official, collation of data. Sometimes at the bedside, when the patient is disappointed, it is important to talk to the patients. And as mentioned, is important and critical for improving quality and safety. And there's little evidence to show that blaming and shaming clinicians will lead to healthcare delivery. So it's important to be open, to look at why did the error occurs, and to discuss it within your hospital, and to decide what will be the effective action that can be taken. And we do know that it's important to do this because when there's an adverse outcome, patients feel feelings of desertion. If you don't talk to them, they want to be informed of errors. And so if something happens and you talk to them, they are less likely to so-called complain or even to the extent of suing you itself. Right? And at the same time, there is also the grief reaction. So many of those who have been trained in open disclosure skills need to recognize that during the open disclosure itself, because they are trying to adjust to the situation. They have a loss and they are grieving as well. And it's important to put that understanding as well. So as I mentioned before, the effective dealing with the patient concerns will actually make it better in the sense there will be a decrease in the litigious intent, there will be an increase in the patient satisfaction, and an increase in the patient's willingness to continue an effective relationship. Sometimes I've seen cases where, where adverse outcome occurs, and there's very good and effective open disclosure. And in the end, the patients and family actually end up trusting the family more, trusting the healthcare staff even more. And that's the power of open disclosure. So we have actually brought everything together. We call this approach called the clinical incidence or the CIM approach. So when a serious adverse outcome occurs, we require a systemic approach and management to be able to do it well. Right? So it's a planned system for our doctors and hospitals to communicate effectively with this. And this will help to reduce litigation and undue publicity as well. So I mentioned about this particular chart itself. The OPE in our hospital now is to look at collating all the data, getting everyone organized, and informing. If it's a very serious case, then of course the hospital insurance, the lawyers will be informed. There will be a review, root cause analysis being done to look at the evidence itself, because the patient also want to know as well. And it's important for us to do this before we so-called meet the patient. And this is part of the thing which I mentioned about that. If the open disclosure at the internal meeting and then the family conference that goes after that fails, then there will be the mediation processes. So these are the steps that we take. Internal planning, we need to plan it well. There is a patient meeting guide that we go through. After we deep as well. CIM is best conducted as soon as possible. You don't really need, sometimes it's important to meet the patient on several times. And sometimes you don't have the full explanation. It's important to meet them, at least to tell them what you have, so that the patient don't feel abandoned. So you can have multiple mini conference if required. So this is our guide, general information of how to conduct the meeting in terms of looking at the meeting arrangement, discussing about what went wrong and our position about the errors, and then addressing the patient concern, which would include of an apology for what has actually happened, that they have suffered harm. And then addressing the quality and safety issues, addressing the issue of waiver and compensation as well, because there's a consideration of waiver of the hospital costs, their out-of-pocket expenses, or even also legal and regulatory requirements. Then we do a debriefing to see what actually have gone on and what were the outstanding issues and how we can deal with it. So these are some of the tips relating to that. I think I won't go too much into detail, basically about conducting the meeting, conducting the conversation, important communication skills, and things. So conducting the meeting, it should be in an appropriate place. The should be informed. They should be invited to bring the support. Because a quiet and private setting is highly desirable. Conducting the conversation, there's the introduction and the open disclosure task. That is, our staff are trained to do the open disclosure task and then to do a summary. So, for example, this is the introduction. Patient conference should be attended to. And these are the open first the ways that lesson will be learned, to develop an appropriate plan and to provide an ongoing patient follow-up. And then, of course, you end up with a summary and thank them for coming and summarizing the key issues. So this is an example of it. We'll go into detail about that. Important skill is to answer the question honestly, avoid commenting on care provided by others, effective listening, focus on problem solving when disagreement arises, and also the issue of compensation. Some of the common pitfalls when we're talking is that we do too much talking. You know, I've seen cases where the doctor just keep on talking, but they don't listen, right? Also, at the same time, the patient going through a grief reaction, you must recognize and provide the comfort for that. And don't try to get into an argument with the patient trying to prove you are right, right? And then very important to express empathy and always try to do so. So this is the what the patient wants: to be listened to, acknowledgement, apology, honesty in the explanation, sincere undertaking to improve care, appropriate follow-on care, and appropriate compensation. So sounds simple, right? But very important to be able to provide that itself. So we, as I mentioned about a grief reaction, patients are depressed and lost, you should give support and care. When they are angry, and usually, you know, in the first instance, they were angry, so listen, acknowledge that what they are angry about. And of course, there's the issue of waiver and compensation. You should acknowledge them, and you should have and assess whether what would be, if it is quite the appropriate quantum of waiver itself. That, of course, will be determined back end, you know, severity, the standard of care, the sensitivity itself. Okay, so this is you have to meet up with the patient and then to discuss about the to negotiate with them about that as well. If, for example, it didn't materialize, then you go through a process of official mediation, which is mandated in Singapore. At the same time, take care of your staff who have been involved in medical incidents, and I think this is a point that we don't seem to be doing well, and so we might make them feel supported and always be on their side, because they are trying their best as well. So just in summary, open disclosure key thing is effective communication. There are important tasks which I mentioned along the way. And in Singapore, open disclosure is a key process of the clinical incident management, which require mediation in Singapore before, hopefully, we will not go to litigation. So thank you very much for your attention. I will stop sharing now. So thank you very much.
Thank you very much for the sharing, Professor Tan. And before we go to the second speaker, to remind everyone, if you have any questions that you would like to ask to our panel of speakers, you can write down your question in the chat section, and then we will discuss it later after our second speaker. Again, thank you, Professor Tan. And now I would like to invite Dr. Chang to give your presentation. The time is yours, Dr. Chang. Sorry, you are still muted. Yeah.
We certainly stand on the shoulders of giants, and it is a simple pleasure and an honor and very humbling to follow Dr. Tan, a worldwide authority. Thank you very much for your wonderful speech. I'm Pancho Chang. I'm going to talk quickly about open disclosure in U.S. hospitals and suggest a pathway for systemic improvement. Next slide. This is what I'm going to cover very quickly. I'll talk about the principles and background, which Dr. Tan has covered in more and better detail. I'll talk about what's going on in the United States, and then I'll spend a little bit of time talking about ways we might improve. Next slide. Okay, open disclosure principles. As Dr. Tan has shown, Australia and the Commonwealth nations lead the way with open, timely communication, acknowledgement, apology, and supporting the needs of the patients and the caregivers. Thanks. Next. In the United States, open disclosure started as early as 1987 when a VA hospital responded to the rising costs of patient litigation. They adopted a new policy of maintaining a humanistic caregiving attitude with those who have been harmed rather than responding defensively or adversarially. And they implemented it by revealing the details of investigations to everybody. In a 2002 study, they discovered that court cases and patient claims dropped. Next slide. Next slide. Yeah. No. What's our next slide? Yes. Okay. Then in 1999, the Institute of Medicine issued the seminal report on medical errors and how physicians deal with them. The report is called To Err is Human, and it resulted in ethics code prescriptions from literally every single U.S. medical society, from the AMA to the American College of Physicians, and so on through the subspecialties. Unfortunately, as Dr. Tan has shown about the fear of litigation, there's relatively low disclosure of errors. Al Wu at Johns Hopkins found that errors get disclosed in only about 30% of cases. Next slide, please. So the ethics rules were followed by laws. About 2/3 of U.S. states now have disclosure and apology laws, and they protect provider apologies from being used in lawsuits. There are reasons that underreporting continues, but the bottom lines are that there's some national recognition in the United States, there's ethics adoption, there's fairly uneven implementation, and there's persistent underreporting. Next slide, please. Well, does money work? The quick answer from the COPIC and the Michigan studies that Dr. Tan has referenced is that some money may make the disclosure less adversarial, but big awards really aren't the norm. Next slide, please. Well, does that mean that we just need more and better reports? What can we do to improve systematically? And what does it even mean to be systematic? Is there in fact a systems approach to human error? And is it possible in this instance? Next slide. Well, systematically for us at El Camino Health means several things. It means understanding and identifying types of errors, educating people about errors and what happens as a result of them, learning and practicing how to support one another in ways that reduce errors, reporting transparently our failures and successes up and down and inside and outside the organization, and supporting this work with money, leadership, participation, and continuous improvement. Next slide. Okay, systems approach to human error. The reason for systems thinking, I argue, is that the science of reliability is, in healthcare, the science of human performance. And if you take an error rate as the amount of errors, the limits to individual product error-free performance is 1 in 1,000. You can enhance this. It's proven you can enhance this with resources, with training, with protocols. And you can use proven techniques like plan, do, check, and act approaches to reduce the event rate. So if frontline workers and leaders collaborate and share their failures and results, I argue that the system can improve continually. I talk about a blunt and sharp approach. Blunt means that the leaders, the people in charge of the organization, design the culture, policy, process, and technology that influences the organization. A sharp approach is the people who actually deliver the services. Dr. Tan is a hands-on obstetrician, and he tells you firsthand about his own way of dealing with these human errors. So bottom lines, I believe that systems thinking can lower human error rate, and I believe that high reliability, there's a reliable way to do this by working in the middle, in between blunt design control and sharp implementation work. Next slide, please. This is Dr. Damante's favorite slide of all time. It's the Swiss cheese one, and it shows simply the path of error. Next, please. This is my favorite slide of all time, and this is what reliability and validity is all about. Next slide, please. GEMS classifies human error into 3 buckets: skill-based, rule-based, and knowledge-based, and discusses what an incidence and prevalence rate is. But basically, at the far left, skill-based errors are slips and lapses and oopses. Rule-based are the toughest thing are with knowledge-based errors, which have to do when something happens and people have no idea, because they haven't thought about it or talked about it, what the contingency is. I'm very fortunate to be surrounded here at the center by people I sit next to who think about contingencies all the time. Thank you. Next slide, please. Is there a way to solve problems systematically? Well, if you think about 3 stages of effective problem solving, looking backwards, begin looking backwards and forwards, but building solutions that are mostly reactive, or finally at the front end, finding and fixing issues before they become safety events. I argue that working in the middle between blunt and design and control and sharp implementation tasks can help in this 3rd stage. Next slide. Okay, if you look at the taxonomy of errors on the left, you see that at the bottom of the pyramid, most errors are near misses. A little higher, there are precursor events, and the sharp tip of the pyramid are the serious safety issues. We've been working from the top down, and I'm going to spend the rest of my time talking about urging people to think about working from bottom up. Next slide, please. Next slide. Okay. If you're going to build a culture of safety, as we're trying to do at El Camino, think about those 3 kinds of errors and apply them here. Human error, at-risk behavior, and reckless behavior. Red line for reckless behavior. But in fact, that is where most of the open disclosure work has taken place, on the reckless side. What if you started moving some of that work towards the first 2 categories, human error and at-risk behavior? Next slide, please. Particularly if you're going to build a just culture in your organization. Build trust for both patients and for providers, and for people who are rewarded and encouraged to provide safety-related information. And the system, as Sylvia is fond of noting, understands that there is a bright line between unacceptable and acceptable behavior. Next slide, please. Next slide. Could we improve the way that U.S. open disclosure works? Well, maybe we could begin by focusing on the type of error, not its severity. Maybe we could work bottom up rather than top down. Begin with near misses and work up. And maybe we could work in the middle, where high reliability organizations work in between sharp and blunt to improve continuously. Thank you very much.
Thank you. Thank you, Dr. Chang, and also Professor Tan for the wonderful presentations. And me, myself, as the public relation of the hospital where I'm working at, yeah, it's problems that I usually meet on daily basis, and I'm the representation of the hospital to meet with the family and do the talking along with the doctors and also the other management, hospital management. And it is very interesting when I saw Professor Tan's presentation about the family meeting needs to be done quickly and no need to wait until the documents are complete, because normally we will of course we do the internal meetings and also to know the whole story, and then we will set time to meet with the family. Usually the internal meeting a lot of time, right? Yeah. Maybe from the participants, are there any questions that you would like to ask or discuss with our speakers? Maybe share about the experience at your workplace.
Nobody in chat. Nobody in chat.
Maybe
Okay.
maybe I would like to ask to our speakers. You were talking about adverse events, and what about near misses? Do we need to do the open disclosure? Do we need to inform the patients when there is no adverse events yet, and even the patient does not know about the near miss event? Do we still need to tell them that there's something almost went wrong? Yeah, okay, Dr. Chen.
Okay, I try to attend this case. Well, if it's a near miss, that means the patient did not suffer any harm. In general, we don't tell the patient because the patient, if you tell them, you may actually alarm them on certain aspect. Although it's possible to tell them. Having said that, sometimes minor incidents and major, if the patient has suffered harm in a very minor way, sometimes the patient may treat it very seriously, right? And some of the patients suffer very serious harm, but you tell the patient say, oh, okay, they expect itself. I think whatever it is, if the patient has any doubt, whether it's a near miss or where, and the patient has something query, you have to address that itself. So it's more towards the patients, trying to make sure that the patient psychologically is okay, because even if nothing happens to them, they thought that they were harmed, they were delayed and there was something, but actually there was no harm in them. Just that the queue is very long and they thought that because they waited and that's why certain things happened, but it actually was not. There's no harm. It's just that it's part of natural disease process. So my understanding is that it's from the patient point of view that we should address rather than from our own patient point of view. But if it's a serious incident, I think it's a duty for us to inform. If it's near miss, we do not need to inform. If it's a minor incident, we have to wait, because by informing them, it will create much more anxiety that you say perhaps not. For example, let's say you give the Panadol, right? Additional dose. Panadol, additional dose, or maybe instead of giving it at 8 o'clock, you give it at 9 o'clock, right? It doesn't harm them, but to us, it's actually an incident. But in this case, we can make a calculation that maybe we won't inform that. So it is we have to think out. It's not that simple to answer this particular question.
Right. So we will see case by case. Yeah, maybe thank you, Professor Tan, for the answer, and maybe Dr. Chang would like to add some.
Well, at the risk of appearing contrarian, I would suggest that sharing near misses with patients is a golden opportunity both to build patient loyalty and to be transparent with the organization. Now, I think the issue here has to do with time, because there is, of course, urgency to get it, to inform patients and to do it as after the act as possible. But I think more people will understand when you say, as your software provider says, as Yelp says on your restaurant reviews, we have heard you and we have changed. These are the things that we have changed. I think that allows you and it allows you to show people the process your patients want to see, not that they were these victims. But they were the opportunity to learn and improve. Thank you.
Okay.
Just to add to this, we actually collect a lot of near misses. So the near misses is for us to actually learn. We don't usually disclose that to the patient because then because there's a time factor, because there's so much thing to say. And very busy environment, we want to collect near misses for the purpose to ensure that if there's a near miss, it won't happen. But if the near miss is related to the patient, right? For example, it's a patient issue, then we might inform because the patient issue from lack of knowledge and that itself, the patients have actually do that. Some of the near misses, if it really is as a patient factor, we might work with them to reduce that. So we do have our advocates, our SingHealth Patient Advocate Network. We work with them for some of these issues that the patient have helped to reduce the real cases, and also, of course, to try to reduce near misses and to learn from near misses. Yeah.
Amazing. Okay, thank you. Theoretically and ideally, we need to still do the open disclosure for near misses, but as for example, maybe if like we almost injected the wrong medicine or medication, but it didn't happen, and we can tell them we almost injected the wrong medicine, but we didn't because we rechecked and everything. So maybe it will give the patient more trust to us that, oh, this hospital do their protocols to avoid any adverse events or something. But on other cases, maybe it's not that simple to do it because, and especially because we never know how they will react, right? As Professor Tan said, that everybody have different reactions. One may be relaxed, and one may be make it a very big of a deal. And maybe both of you can share with us the biggest challenge in open disclosure practice in your country.
Well, it's just like any other country, because when the incident occur and it harms the patient, our natural tendency is sometimes not to tell the patient the full story, right? I'm not talking about near miss, but even in cases where patient is harmed, and to be able to tell the patient, and that's a natural obstacle for quite a number of people. And we are trying to say that, no, that is okay. In fact, that is the correct way to do so. But after having gone through, because sometimes it may not be due to the person's concern, it may be due to the, as the blunt end, the systems and the leadership itself that actually, the person may have injured because the way the medication is being so-called prescribed, the way that the environment is very busy environment, and the letterings are not clear, and all this. So these are all the system issues that may come about, and that's why it's important to have and also an open discussion within the healthcare system itself. To be able to see what are the issues. In the past, it used to that people are fearful because once you admit that you are a mistake, you are the sole person to blame. So it's a blame person, and that's why Dr. Chen has mentioned about the just culture, which is pretty important. Without the just culture, it won't happen because people would not be willing to disclose. Right. So it is actually part of the thing. To have good open disclosure, you need to make sure that your culture, there's good just culture, we're looking at the system as well to be able to promote that. And that getting this whole system out, that is the main challenge. Thanks.
Thank you, Professor Tan. I think it's the same here in Indonesia about the just culture. And maybe how about in the US? What is the biggest challenge to in open disclosure practice in your country, Dr. Chang? I'm sorry, we cannot hear you. Okay.
I think you're muted again, Dr. Chang.
Sorry, Dr. Chang. Yeah.
I think the biggest challenge in the United States for open disclosure is having 50 states with 50 sets of laws. But from a scientist's point of view, the biggest challenge is the lack of comparative effectiveness studies that allow us to compare different results in different situations. Thanks.
Thank you. Okay, another question is what are the steps to build open disclosure in a hospital?
Sorry again, what are the?
What are the steps that needs to be done to build the open disclosure in a hospital?
Well, it needs time and patience, of course. And I think there's have to be a leadership commitment. As in all things, if your leaders don't take into action. So for example, if you want to have open disclosure, the hospital leadership must say, okay, I think it is good for us because it is important to have that. Let's take it from this way that we build the culture, the culture where we and in terms of the error, and we look at the way where we partner our patient, right? So first step, once you have the leadership commitment, the rest will be easy because resources will come through, and also the time commitment will be made available, right? The time you'll be prioritized for that.
Okay, thank you. So it needs to be started from the top management to build the culture. Oh, I think Dr. Chang is out of the Zoom meeting. Oh, hello, Dr. Chang. Wait.
Yes. What can I?
Yes.
What question can I answer?
Yeah. What are the steps to build the open disclosure in a hospital?
I think Professor Tan has laid out the first and most important thing, which is to build a culture. But the culture is built by the people at the top, and understanding how that works is important. On the other hand, if you use a blunt, sharp approach, the people who deliver the services are the people who are going to see the need to involve patients early. In the United States, we participate in something called patient-centered care, and use techniques like community-based participatory research to involve patients. The big problem that I think people face when they start to bring a new constituency in is simply the law of small numbers. There is a small sample size, and there are lots of sampling assumptions that result from this. But that's only to say that the work is at an early stage, and that I'm confident that Dr. Tan and his colleagues are well on the way to building those kinds of systems. And I look forward to seeing the results.
Thank you. Thank you, Dr. Chang. As mentioned by Professor Tan also on his presentation, that open disclosure does not rely solely on doctors, but also so many areas, including government and the policy. Indonesia, there's still no policy that about the open disclosure to protect clinicians or healthcare providers. So what do hospitals in Indonesia need to do?
Well, to advise that is actually beyond my pay grade. I'm not at the minister level. So, but what I can say is that you have to evolve along the way, because it will depend on the patient expectation, the healthcare expectations, and the government itself. So as time evolves, you move along itself. In Singapore, we felt that when you want to discuss about what Dr. Chen is about, the looking at how we analyze errors and trying to have a good discussion about that, using a Swiss cheese approach to do that, right? So that's why we have quality assurance committee, and we let them discuss, and the issues will be within their four doors itself, because they have to be as transparent and open as far as possible, look at ways to prevent things from happening in the future based upon what they have. So that allows for very good discussion about looking at all the areas, the system issues, the manpower issues, so they can come to do that. And once they have an understanding, they can then come together and decide what to tell the patient itself, as much as they can from the combined understanding about that itself. So I think this does promote. And if the patient, we try not to let the patient sue us. There are several steps. Number one, if there's good disclosure, transparent, the patient is happy, they won't go to litigation. And even if that fails, we have a process of mediation, arbitration, to discuss about that. Only very few cases go to litigation. And in the litigation, our judges and lawyers do not award huge sums. They award just enough to be able to cover, because if you award, like humongous kind of amount, like 100 million, $200 million, you're going to bankrupt the system. Basically, healthcare costs in the future for all the rest of the other patients will be bankrupted, because the premiums will all go up for the doctors, as well as for the patients. So that's why the government has, if you understanding, about the system, so we have this legal protection to discuss openly, and also we have this understanding by judges that they will encourage as little litigation as possible. But the patients have no avenue, but they have to go through all these processes itself, and the healthcare system.
Thank you, Professor Tan, for the answer. Maybe Dr. Chang would like to add. Okay, thank you. Thank you for the time. Thank you for the answers that you've given to us. Thank you for sharing all your experiences and knowledge in your field of expertise. I think there are still so many things to do in Indonesia to, to implement this open disclosure, because it needs to be built from so many aspects. And I would like to maybe resume our webinar. So open disclosure is an important task to do in the case of adverse events and near misses, if I may add, or when patients experience disappointment. And in both US and Singapore have already implement the open disclosure in their daily practices. Open disclosure is important to improve the outcome for the patient, for the hospitals, and also reduce the likelihood of complaint and getting sued. It is already proven by some by some studies, and also again, open disclosure practices do not rely solely on doctors, but also the whole system in the healthcare, including the government and the policy. Thank you so much, Professor Tan, again, Dr. Chang, for the time. And I would like to apologize if anything that I say or do is wrong. And thank you for the participants. And I will give back to the host. Good afternoon.
Okay, thank you very much for Dr. Sylvia as the moderator of today's webinar. And we finally come to the end of today's agenda. Those are the agendas we have presented to you all this afternoon. And we also would like to thank especially to Professor Tan from Health Institute for Patient Safety and Quality Singapore, and Dr. Chang for Fulbright Specialist Patient Safety and Quality Expert from US, and also our moderator today, Dr. Sylvia Sumitro, and the audience for the participants. To interest in this webinar series Patient Safety Open Disclosure Practice in the US and Singapore Hospital. We believe that the information presented here will be beneficial and inspire to all who attend here. And thank you again for joining us today. We appreciate your time and hope to see you soon again. And wassalamualaikum warahmatullahi wabarakatuh.